PA school and just PAs, right? There is this camaraderie. There's not competition. We are all here to like help each other out, support one another. Hey, you need help learning, the digestive system. I got you. Can you help me with the nervous system? Let's work on this together.
Hi, everybody. Welcome to eShadowing. Happy Monday, everyone. As you all know, I'm Rodeline. I'm the host of eShadowing. And tonight we have Aleece Fosnight here with us. Hi, Aleece.
Hi. Thank you so much for having me. So excited to be here.
Yes.
Yeah, absolutely.
So Aleece is a PA in sexual medicine and urology, which is a very special, especially sexual medicine specialty. So we're excited to learn more about what she does. And she not only does that specialty, but she owns her own practice. And so we're also, ready to hear about her work as an entrepreneur and how she was able to start her own practice. And she's in North Carolina, right?
Absolutely. Yeah, my practice is in Asheville, North Carolina.
Awesome. So we're going to dive right into it. So Aleece, can you tell us about your journey to becoming a PA and your why PA things you did and how the application process was like for you?
Yeah, absolutely. So PA actually was not something that was on my radar. I loved medicine. I wanted to be a physician from the time that I think I was born. Until, into high school, like that was just my trajectory. So no one, I don't think, ever had talked to me about becoming a PA or what that was about. My mom is a medical assistant and has been for the majority of her life. And she had worked with PAs, but again, nobody had ever mentioned anything to me. So I actually applied to medical schools, wanted to get in, didn't get in, and thought, okay, well, what else is out there? I really want to do medicine. And so a couple of individuals had reached out to me and said, why don't you do PA, right? It is based on the medical model. And again, I was like, this is great. I don't have to go to medical school as long. I don't have to go to residency. I don't have to specialize, right? For me, I love change and I really embrace it. So for me, it was like, I could do whatever I want to, and I could be in emergency medicine for a couple of years. And then if I wanted to switch over to women's health, or if I wanted to do internal medicine, it was that I liked the flexibility that I wasn't like locked down into one. And so I had to take a couple of prerequisites before I could apply. I had to take medical terminology, which is weird. I have a bachelor's in health science studies, and we didn't have medical terminology. I went to Brevard College for my undergrad, which is in my hometown. And so it was just hysterical that I needed medical terminology and I think like biochemistry. There was something else that I needed. And at that time, when I looked at PA programs in North Carolina, so we're talking, I applied, 14 years ago. That's really hard to believe. I literally put my application into PA school the day before I got married. Yes. Yeah. So I could always remember when I applied to PA school because we just celebrated our 14th wedding anniversary. So
congratulations.
Thank you. And so, I really liked the fact that I didn't have to go as long to school. I could jump in right away. That's what really appealed me to the PA profession. So looking at PA programs here in North Carolina, at that time, 14 years ago, there was only 4 programs. And all of them were on the east side of the state. I'm in Asheville. And so I was like, I don't really know. My brother and my father-in-law had gone to the University of Kentucky, and we were always Wildcats and things like that. When looking at their PA program, they have a January start date. And so you could apply earlier, and I thought, okay, this is great. I'll apply to UK, and if I don't get in, I'm not going to waste all my money applying to 8 other PA schools. And actually got in right away. So I put my PA application in to the University of Kentucky's PA program the day before I got married. Came back from our honeymoon, found out that I had gotten an interview, went for the interview in September, I believe what it was, early September, late August, something like that, and then found out that I got in. So it, in late September, early October. So it was just really, really fast how it all kind of went down. So when we think about the PA profession from 14 years ago, we have 14 PA programs now in the state of North Carolina.
Wow.
So, we really, PA programs me, when I was applying, I had a lot of limitations with applications. I still had to take the GRE was one of them. Had to have all these clinical hours. I had done an internship in the emergency room when I was in undergrad. So having all of these clinical hours was, I had really lined all of that up. I had volunteered with our local rescue squad. I volunteered. My mom had worked for a family physician at that time, so I shadowed him going around to different places. He was a medical examiner for the county too, so I got to shadow him on some cases. So I wanted in. Give me all of the experience I wanted in. So I think that really actually helped with my application process of the diversity. I was taking care of my grandmother at that time. She had her bladder removed for interstitial cystitis back in 2000, so helping with ostomy care and things like that. So really wanted to pull home of why medicine and why I wanted to go into the PA profession.
That's awesome. Great. Congratulations on, all your accomplishments, and of course getting into PA school the first try, and it was just like it was meant to be.
I really do think that when you are in the right path, it's hard and you got to work for it. But when you put in the work and you put in the dedication, you have the tenacity and you want something, right? It will unfold and it will seem like it's easy. I struggled getting into medical schools. I was super young. I was only 20 when I graduated from my undergraduate program. I had finished high school early. I took dual enrollment classes. It was very driven, but I think that hurt me a little bit too, because a lot of my colleagues in PA school, my classmates were in their late 20s, early 30s. Like it wasn't, uncommon I think our average age was like 32 going through PA school. So, it's never too late to go. So, and it's competitive, man. It is super competitive. You would think that with more PA programs out there, like, oh yeah, no worries, I can get in. But when we look at it, it's actually more competitive to get in PA schools now than in medical school. So it's just, very interesting how the times have shifted. So
thank you for that. So we already have questions coming in from students. One student wants to know, what was your personal statement about primarily?
So my personal statement was actually very reflective of how medicine has really shaped me. So I usually will tell students, I precept a lot of pre-PA students. I'll do preceptorship for PA students as well. I love to teach and I love to help others learn and grow. So for me, when I use my personal statement, I utilize my own experience. I actually had a severe allergic reaction called Stevens-Johnson syndrome when I was 9. I had
a back trip or something.
Yeah, I was on amoxicillin. So lots of ear infections. Yeah, I had lots of ear infections growing up. So it wasn't uncommon. I think my mom had like a bottle of amoxicillin in the pantry. Like that was just standard, for us because I just had ear infection after ear infection. And I got misdiagnosed at my pediatrician's office with chickenpox. I got misdiagnosed in the emergency room. And it wasn't until my mom's physician that she was working with at that time came over to the house, made a house call and said, she needs to be admitted now, like there's something wrong. So I was actually at Akron Children's Hospital up in Ohio for 2 weeks. And I really reflected on that experience that I had. I loved the interaction. There was a PA that actually took care of me then. And so I really reflected upon that and paying a personal touch. So talking about my own personal journey in the medical field and the things that I had to work through that and wanted to be an advocate for patients. So for me, that was really why I loved getting into medicine was, again, my own personal experience. Going through, seeing what my grandmother had gone through. She went through a 5 bypass, so 5 cabbage, when I was like 12 or 13. And then, of course, taking care of her when she had her bladder removed. I was 16 when that happened. And so, just being able to reflect, I think really pulling on your own personal journey. Don't make up some fluff. They'll see through that. They really will. So, really pull at your heart. Why? What is your why? And that's definitely what we'll talk about too when I decided to open up my own business. My why was because I was being limited with my own hospital system. And so your why, and it will resonate through to those reviewers, and you want to stand out. It may sound silly and crazy and whatever else, but that's what you want.
Yes, thank you so much. Yes, super. You just dropped some gems, guys. That's some great advice. I always tell students to, tell your story, your why, get a little personal, what's your journey, be honest about it. So thank you for sharing that.
Yeah, be vulnerable, right? And that's so hard, right? Is to be vulnerable and like put it all out there. I was kind of mentoring one of my really good friend's husbands to help him to get into PA school, and he really struggled with addiction growing up. And I said, write about it, about it. Be open about your experiences and how you want to advocate, and you want to be in emergency medicine, what that means to you. Right. So really pull on that, like I said, and that's going to help you stand out.
Yes, and that shows resilience as well. Mm-hmm. Yeah. So can you tell us about how PA school was like, didactic versus clinical? Did you do a urology rotation? So how was PA school overall like?
I loved PA school. I am that nerd, that student. I love learning. I ate it up. I love the human body. I love how everything is connected, and it's all processing, and the kidneys and filtration system and how our body processes. I love it all. Yeah. And the funny thing is that I think I was destined to do sexual medicine from day one. I was always that person in high school where people talked about sex and their sexuality and sexual health, and always wanted to debunk those, you can't get pregnant on your period, and all of those funny things. Yeah. So in my anatomy, and I hear that not all PA schools do dissection and have an anatomy lab or cadaver lab, and I'm super bummed about that. And I know several medical schools are like that too, but for me, that's where things clicked, and I can still remember seeing the muscles and seeing the nerves, because when we got down to the genitals, we had a assigned female at birth cadaver, and so we were dissecting out around the hip, we were around the vulva and the labia, and we actually dissected out the pudendal nerve. And so, and that's going to be the sensation and the innervations that go to the vulva, to the clitoris, to the distal third of the vagina. So for me, I was apparently I am destined to do sexual medicine and women's sexual health. So, that was one of the very vivid memories that I still have from anatomy lab, and just absolutely loved it. Long hours. So, in PA school, right, they tell you that this is your job. And I have worked since I was 12. So you're telling me that I can't even work 10 hours a week and whatever. That was very crazy. I've got to be able to work and support my family and things like that. But it is. You realize that this is your job. This is what your time is meant to doing. And I did it. I studied 24/7. I think I studied in my sleep, put my books under my pillow so I could maybe somewhat absorb it or something, right? A little osmosis, which is not really how it happens, but that's what we'll say. But yeah, and it was really funny because I learn out loud. I have to talk it out. I have to understand it. I have to process it. I am not a memorizer, and I will tell you, those that memorized in my class struggled.
Yes.
Struggled because they didn't understand concepts, right? It's that critical thinking, putting the pieces together. That was part of it. So the person who I studied with the most was actually my mom. I would call her up. We would be on the phone for hours, and I would just talk out concepts with her. She probably could be a PA at this point too, just from learning so much of what happened. But really talking out was really helpful for me during that process. And I wrote everything out. Listen, I got so many of my notes and my notebooks still, and just highlighting. For me, again, that visual too. So being able to process that. So that was, I had to hear, pharmacology was my struggle. Just understanding all of the drugs and how they process in the body and the mechanism of actions and all of this kind effects and interactions and contraindications and things like that. That was, so I will say, pharmacology kicked my butt. I struggle, which is funny because I feel like on my pharmacology side of my drugs now, I'm down pat. But again, I'm 11 years into this crazy career. So, and then during my my clinical years, I loved women's health. I realized when I was in my didactic year doing my master's thesis, I wanted to learn more about women's sexual health. So I actually did 2 rotations in women's health, and then I did an elective in urogynecology. And I actually did that urogynecology rotation over in England. So I got special permission. We have an exchange program. There's a UK program at the University of Wolverhampton, and just outside of Birmingham, which is just outside of London. And so their UK program has a PA school. So it's so funny, we exchanged with our UK program. And we actually, I hosted one of the PAs from the UK. So it was really exciting. So I decided to do my urogynecology rotation.
Oh, wow. You know, we're talking about it really quick. How was that experience doing like PA school or like your rotation in England?
Oh my gosh, I loved it. I actually was in their sexual medicine clinic, which is very different. So we think about infectious disease or HIV management, sexually transmitted infections. So over there, it's called a sexual medicine clinic. And it was fascinating. You know, we were monitoring people's CD4 levels and viral loads and medications and having them come in. And we did a lot of counseling. If you can't tell, I'm a talker, and I love talking. I've never met a stranger. Like, that's the way I am. So it was really interesting how we were able to integrate counseling with medicine. I was like, I love this. This is really like what I want to do. There's not many regrets that I have in life, but my one regret is I actually got a job offer when I was over there. But my husband does not travel overseas and things like that, which is fine.
Yeah.
So I decided to come on home. But yeah, so women's health, I really want to do, like I said, female sexual health. That's really what I wanted to do. My first rotation was in family medicine, and I had a wonderful preceptor. She really walked me through, right? Because that first rotation, you were scared. I think I cried. Like it's all of the emotions that you actually get with it. And so, but she was great, and I spent 8 weeks with her with my family medicine rotation. She was great. My surgery rotation was at the University of Kentucky's Medical School and their surgery program, and I hated every minute of it. I did. I cried every single day, and it was with medical students. And I will say, PA school and just PAs, right? There is this camaraderie. There's not competition. We are all here to like help each other out, support one another. Hey, you need help learning, the digestive system. I got you. Can you help me with the nervous system? Let's work on this together. Right. There is a competition in a whole different level when it comes to medical school and medical students.
Really?
Oh, yes.
That too. I didn't do too many rotations with med students. I did for my pediatric. I had med students, and I think some emergency medicine. But I remember that. I remember that too. Yeah. Especially like when it came to getting kids. Oh, that, yeah.
Yeah. So I was the only PA student that was on that sort of rotation. I was the only female medical student too. Yeah. And so this was like, well, I'm gonna go and do the general surgery clinic. You can go to the breast clinic. Well, I was excited. I love women's sexual health. Yeah. So I actually got it. So I think it actually turned out in my favor because I actually had the residents request me on surgeries. So take that medical student.
Right.
But no, and so at first, again, my surgery rotation it sucked, and it was tough, and I think that my program didn't prepare me enough for the surgery part of it. Basic stuff as far as what is sterile, how to don on, your cap and gowns, and all of the gloves and things like that. But surgical technique and retraction and things like we just weren't there. So that was a really good feedback that I provided to my PA program. And that was a great thing too, is that the University of Kentucky loved student feedback. How can we make things better? So I always felt like I had a voice in it too. And I didn't tell you also, I was our class president for our UK class of 2011. So I really felt like I needed to have a voice and to carry that out through with my other classmates for sure. If they had a concern or an issue, I really wanted to be the voice for our class. So I never felt like with my faculty that I couldn't explain or couldn't ask for help or give them feedback about like how I was feeling. So yeah, that was kind of my clinical rotation. But overall, I had a great experience and loved it all.
Nice. So before we dive into working as a PA, we have some great questions from students. One student wants to know, what is the biggest difference you noticed about the way the healthcare system works in the U.S. versus the UK?
So you would think, so it's a national health system that we have over in Europe, right? And so it is part of your taxes. It's not free healthcare, which is what I think happens a lot of times in our thought process. Over in Europe, it's all accessible, everybody's taking their medicines like they want to and things like that. And that's not really the case. There's still a lot of compliance issues when it comes to overall health and understanding why you're taking a certain medicine. One of my patients in my urogynecology rotation, she was asking a lot about like her bladder and what was happening. And there was just a lot of lack of anatomy and just self-awareness of body image and what was going on with her pelvis and her bladder and why she was having overactive bladder symptoms. So again, and I still see that here, in the United States as clinicians, we're not the greatest of educating our patients, and we forget that education is a treatment sometimes too. And if we understand how our body works, we have a better understanding of what our bodies are going to go through and kind of that process. The great thing about that I loved the UK that we do a lot differently here in the States is they want to maximize everything else before they implement surgery. So for my patients who had urinary incontinence, right, a lot of urologists or even urogynecologists will want to put a mid-urethral sling or do surgery to support the bladder, something like that. Over in the UK, they utilize what's called physiotherapy or physical therapy. You have to go, so even before you get on medicine, you have to go and for like 12 weeks and fail physical therapy before you actually get a medicine, right? How crazy. We do not utilize physical therapy as much as we should here in the United States. So I will say, and with me working in sexual medicine and pelvic health, urology, gynecology, I utilize a pelvic floor physical therapist all the time. And, but we have the mindset here in the United States, like a chance to cut is a chance to cure. And I will tell you, I see a lot of patients with complications post pelvic surgeries that could have been avoided had we possibly sent them to physical therapy first or did some other intervention that possibly could have helped.
Wow. Awesome. Okay. We'll answer that later. So we have a question about surgical opportunities in sexual medicine, but we'll get into that when you talk about like sexual medicine. So what was your experience like as a new grad? Did you go into sexual medicine or where did you start working?
Yeah, so when I was in high school, I actually worked for a urologist, and I would answer phones, I would have charts, because it was paper charts back then. I actually was trained on how to do urinalysis and dips and kind of taking patients back. So definitely had that experience. So this urologist found out that I had an interest in female sexual health, urology. So the interesting thing when I did my master's thesis on female sexual health, and I really thought that a lot of my articles were going to come from gynecological journals. And that is not the case. Sexual medicine, all of sexual medicine falls under urology, which is just crazy. We just don't think about that specialty. Yeah. So I was like, okay, urology, I can do this. So when I did my master's thesis, all of my articles were coming from these urology journals. And what really pissed me off was that we had so many different options and treatments for penis owners for men, and we had nothing for women. I was super pissed off. And so I was like, okay, this is what I want to do. So I have always kept in contact with this urologist that I worked with and things like that. He wrote me a recommendation letter when I applied to PA school. So he caught wind of what I was doing, and he called me up. And I think this was right before I went to Europe because it was my last rotation. I had to get special permission because not only did I go to Europe to do a urogynecology rotation, but I actually went to the World Association for Sexual Health Conference, which was in Scotland. And so I was like, I want to put it all together. I love sexual medicine. Please give me permission to do this. So anyways, it was right before I left for that last rotation that I had this urologist give me a call and said, hey, I hear that you have an interest in female sexual health. Do you want to come back home and do female urology and female sexual health? Dream job, right? Like, this is exactly what I wanted to do. So I was very, very lucky and actually got to do what I loved coming right out of school. So packed up, we had bought a house in Kentucky. And so my husband stayed behind, fixed everything up. I moved with my mom. Like, I've been married for almost 3 years, like having to move it back with my mom. But, recognizing that it was just super temporary. So started out, and he treated me like a resident. I mean, it was just literally, he wanted me to work up that patient until it was surgery and he needed to intervene. So, all of the new patients, I would see anybody that had a sexual health concern, they came to see me. But again, it was hard. And for those first 2 weeks out of school, right, because you're trying to apply everything. You've passed your boards, you're like, okay, this is great. And you get in there and you start seeing patients and you're like, I don't remember anything. I just learn. And, so it's very interesting starting to apply, but it gets easier. It really took me a good 2 years to really feel comfortable with what I was doing in that specialty. So for me, like I said, I jumped right in and did urology right away, got to do sexual medicine right away. Although I loved, I really wanted to focus on female sexual health at that time. His practice was probably 85% men, 15% women. So I learned to love my penises and prostate owners. And, it was great. It was a great avenue for me to open up the questions to say, if they're coming in for their Cialis or their Viagra because they have erectile concerns, I said, well, are you using this for like solo play or for partnered play? Well, partnered play, of course. I'm like, okay, well, does your partner know you're here is the biggest question, right? And those are a lot of times things that, even in PA school, they don't teach you a lot of how to have, again, that conversation. So I remember when I was over in England and they did a lot more counseling, I really pulled a lot of more of that counseling conversation with my patients, so they didn't feel like they were just coming in, giving them their medicine, and then they were gone, right? I really wanted to establish a relationship and a connection with my patients.
Okay, so that's great that you got right into sexual medicine, like right outside of school. Is that the only specialty you've done, in your 11 years as a PA? Wow, that's amazing. So you're a pro. You're the go-to for this.
Yes, and so like I said, gynecology, women's health was my love too. I actually had an opportunity to do almost like, I guess, a side hustle or something like that with our local health department and their family planning clinic. So in our area, the majority of our patients are over 65. We have a high retirement population. I mean, they were coming in with a lot of pelvic concerns when it came to overactive bladder, some pelvic pain, vaginal atrophy, erectile concerns, Peyronie's disease, all of these types of things. A lot of kidney stones. We have a real kidney stone by the belt here in this area. And so it was really fun to kind of add that layer of gynecology with more adolescents, young, teenagers, women in their 20s, to really help to be an advocate for them, to give them an opportunity and to empower them with their reproductive health. We come into this and it's always very negative, right? Like, don't get pregnant, don't get an STD, don't do this, don't do that, don't have pleasure, da, 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 da. And for me, it was so refreshing. I got to come in and ask, like, well, when do you want to have a baby? And what is, like, your sexual encounters look like? Are you having fun? Is it consensual? Let's talk about, is it pleasurable? Like, how is that feeling for you? And so I really enjoyed that aspect of it as well. So I did get to round out the other piece and not just do straight urology, but gynecology as well. And I would first assist sometimes for our gynecologists. We all shared one building, which was really nice. So a lot of times I would go in and first assist with them, also with hysterectomies and things like that.
Okay. So that would basically help answer the question about surgical opportunities in sexual medicine. You mentioned hysterectomies, and what other surgeries would you do?
Yeah, so I first assist on all of the surgeries that we did in the urology world and specialty, whether that was assisting with kidney stone extraction. I did a lot of procedures on my own too, so like I did prostate biopsies, prostate ultrasounds, pelvic ultrasounds, transvaginal ultrasounds. I do cystoscopies where we look inside the bladder. I would run urodynamics, which is what we do to help look at the function of the bladder. So I got to do, all of those types of things. When it comes to sexual medicine, I also see a huge queer trans non-binary population.
That was my next question.
Yeah, so literally a year into my practice, I went to this transgender health conference in Asheville in 2012. So again, like I said, a year after I had graduated. And there was a primary care provider that was up there talking about barriers to care, especially when it came to pelvic health. And I was like, I'm in urology, everybody needs help. And so I made a connection with her afterwards, and she started referring a lot of trans non-binary folks to me to talk about hormone therapy, urinary tract, vaginal dryness, because that happens when you're a trans masculine person and you're assigned female at birth. So it was all of those things that I just started to really unfold. So I do a lot with gender affirming hormone therapy. We do orchiectomy, so removal of the testes as a first introductory surgery for our trans feminine patients. I'll assist with hysterectomies for our trans masculine folks. What other surgeries do I do? I'll do vulvar biopsies. I do a lot of procedures. I do a lot of procedures in the office more than surgeries, right? Because there's a lot more that you can do when somebody comes in with pelvic pain, interstitial cystitis. Surgery isn't necessarily the first thing that we jump to, but I do have a lot of PA colleagues across the country that are first assisting in vaginoplasties, vaginoplasties, so all of this bottom gender affirming surgeries. People are in there, PAs are in there first assisting. And the way that I was the first surgical PA at our local hospital. And so being able to let them know I am capable of doing this. I had to go through all of the boards and get permission and get the blessings from the CEO and all of these types of things to really show that this is what I'm capable of doing. And when we think about the ways that PAs are trained, right, we're medically trained. So we are able to think in that surgery model also. You know how to retract, you know the layers. Right. Listen, I did a lot with scrotal surgeries and penile surgeries when I was just in urology. And listen, I would be in there opening for my surgeon, and he would walk in because he just finished the case, across the hall. We got started, he would do his thing, and then I would close. Again, he treated me like a resident. That's exactly what a PA needs to be treated as. So I feel so much gratitude to him in allowing me those opportunities to really expand my scope and my technique. So it's those types of things. I do IUD placements, next one on. So I do a lot of reproductive care for my queer population as well. It's really difficult for somebody who identifies as non-binary or transmasculine to sit in an OB/GYN waiting room when there's a whole bunch of pregnant women and you look very masculine. So, I don't do any OB. I still see cis men, cis women, and again, just a huge trans non-binary population. So creating this very safe space for folks to come see me has been just, I feel so honored that I get to do the work that I do.
Yeah, and I was going to mention that I don't know if PA school has changed, because when I was in PA school like 2014, but because in PA school I didn't get taught that. Like sexual medicine was like STDs, and that's it. They didn't talk about gender identification, gender affirming surgery. years ago, but I think I'm hoping that they're, more open in discussing that, because that is work that we'll have to do, and the population is growing. We'll have to even learn how to talk and, have that bedside manner and make them comfortable and create a safe space for them. So yeah, I don't know how schools like now, but I hope that they're, teaching that too.
They're still not doing as good of a job as what we could do. And I tell so many of my PAs that are in academics that are teaching, I'm like, you don't have to necessarily do a whole curriculum or whole semester just on sexual medicine. Sprinkle it in. It's so important, when you're talking about doing an intake, asking patients, what pronouns do you use? How do you identify yourself? What is your gender expression? What is your sexual orientation? And I always equate it to genitals, right? So when my patients come in, I'll, and again, I'm a little biased because I already know them coming in. I have a really good intake form that talks about, what sex you were assigned at birth. And we have female, male, and intersex, because 2% of our population is intersex too. We've got to make sure that we include them on that also. So we have that on there. And then we have gender. And I have gender fluid, gender queer, transmasculine, non-binary, trans-feminine. We have the whole list on there. And I always will have an other, right? Because somebody may not identify as all this. And for us to put people into boxes is not okay. We want to be able to have an open-ended dialogue with these individuals. And then when we talk about orientation, I will always ask them, what are the genitals of your partner? Is pregnancy a concern, in this situation? Do we need to talk about contraception, barrier methods, STI protection, right? And nobody wants to talk about anal sex, but it happens, right? And we have to talk about protecting yourself and what does that mean, and what am I putting myself at risk for? When we think about HPV, 90 to 95% of all anal rectal cancers are HPV related, right? So how does that happen? I sit in a cancer conference every other month, and this always comes up when we start talking about head and neck cancers and anal rectal cancers. It always is the elephant in the room. It's with HPV positive, their cancer and whatever else, and I'm like, how did it get there, guys? Conversation. And then I always chuckle with my dentist because I will always ask him, are you checking for HPV? Are you swabbing? Are you doing all of those types of things? Because I tell everybody I can tie sex into anything.
Yeah. Awesome. So one question we have is, what personality traits do you or your colleagues value in sexual medicine?
Oh, personality traits. Gosh, you've got to be, I think just very laid back. I would say I definitely have mellowed out a lot over the past several years. And personality trait, you've got to be really ambitious and tenacious, because you're talking about something that is very stigmatized and very taboo. So when I was developing my practice, my private practice, so it's Fosnight Center for Sexual Health. And for a long time, I really debated, do I put sexual health in the title, right? Do I just call it the Fosnight Center? But I didn't want to falsify the types of services that I provide. And sexual health is an umbrella term for all of the things that we just talked about, right? It's how you identify as a person, it's how you feel in your body image, it is how you see yourself with another person or persons, right? I do have a pretty large polyamorous relationship community in our area too, right? So you can't just talk about the one partner that you have. I had a patient today, and I said, how many partners do you have, and what are the genitals of those partners, so I can make sure that is pregnancy a concern at first? And there was 3 different partners. So we're like, okay, well, how frequently are you engaging in sexual activity with each of the partners, and what? So you have to have those conversations with them. So personality, you have to be pretty open and pretty comfortable with talking about tough topics, and patients struggle. They walk through the door and they made that appointment, and they're there to talk about it, but it's still difficult. They have a really strict religious upbringing, or they never talk to anybody. No one's ever asked them about how they feel about their genitals, or what's their body image like. We talk a lot about BMI and weight and things like that. I don't weigh my patients, the BMI is racist. It is outdated. It is social, like, let's be real here, whatever else. All bodies are good bodies, and we come in all shapes and sizes, and we need to stop talking about losing weight because your back hurts, right? Or, I had one patient who sits in a large body, and assigned female at birth, identifies as female, and she was presented because she had a lot of abdominal pain and a lot of pelvic pain. So, and she had seen so many other providers, and she, one of the providers said, well, if you could, just lose some weight, that would be helpful. So she said, so I'm going to go out to the parking lot, cut my leg off, lose 20 pounds essentially, and my problem is going to be solved. That's what you're telling me. And so when she explained that situation to me, light bulbs just went off, right? We focus too much on bodies and things like that. So I really talked to people more about, what do you do to move your body? What do you do to have fun? What do you do to just like get some cardiovascular activity going? And, and how do you feel about your body? So we can embrace curves and we can embrace change, all of those types of things. And so, again, it's hard to have those conversations, but we need to just really take a step back and have a much broader lens. I think we get so pigeonholed when it comes to medicine that we only see one thing. So even in sexual medicine, right, blood pressure medication and diabetes medication, all of those things affect your sexual response cycle. Again, we didn't talk about the sexual response cycle in PA school. Nobody knows what I talk about when we talk about desire, arousal, orgasm, and resolution, and the spontaneous and the responsive desire that happens with it also. So, it's just very interesting. And like I said, I've been a social butterfly my whole entire life, and so I just could talk to anybody.
I think this is great. Like, you seem to have like personality for what you do, your patient population. So non-judgmental. Like, I'm sure there's you create a relaxed environment where it's comfortable to talk to you. Because going to a doctor, like, people get scared, or their doctor's office, they probably don't tell the truth all the time because it's nerve-wracking, scary. So I think your personality is great.
Yeah, and that's, it is. When you talk about sexual health, the World Health Organization recognizes sexual health as part of your overall well-being, and there are screening questions that we should be asking.
Yeah.
But even I will joke with my gynecologist and be like, you didn't ask me about my sexual health or my sexual practice. You're assuming that I'm in a monogamous relationship, right? Like, so we have to take a lot of those assumptions out and ask those questions, because what happens is 72% of our patients won't bring something up because they don't feel like it's important. They realize that if it's something important, their provider is going to bring it up. So you as that provider have to bring that up. So for all of you that are writing like little notes about like, put this in your personal statement, right? Like, you want to be that provider that brings up these hard conversations to help your patients feel more comfortable to talk about the concerns that they have, because I guarantee you they are not alone. Everybody has a similar concern, has a similar question, especially when it comes to their sex and sexual health.
I feel like you need to teach a talk to PA school.
Listen, I want to reach out to PAEA and develop some sort of sexual health curriculum.
Yeah, it's definitely, somebody said that in the chat, that it's not talked about enough. It's definitely not discussed enough. There's so much more to it than just like, gonorrhea, chlamydia, treating, doxy, whatever that thing. Yeah, there's so much more to sexual health that we're just kind of taught that, treat the STD, that's it. And, if they want to become pregnant, give them, or they don't want to become pregnant, give them, condoms or birth control. That's it. That's it. But there's so much more to that.
There is so much more. And, when we think about like culturally and the way that women just have been, again, we're talking about like cis women and those that are female presenting, right? We have this objectification that goes along with them so much. We were there for somebody else's pleasure and not our own. And what I find that I do a lot in sexual medicine is I do a lot of permission giving, especially when it comes to my cis women. You absolutely have the right to take orgasms into your own hand, like literally into your own hand. Like, let's talk about that. And just being able to talk about your own anatomy and that you have this amazing organs and structures and what it can do and that sort of thing. I mean, I still have women in their 30s and 40s that don't know that their clitoris is like a wishbone and that the majority of it is internal, right? They think it's just that little knob that sits on the outside, and that's so not the case. or they think that they pee and have their menstrual cycle from the same area. So, I mean, it's just, I tell you, we don't do a good enough job with sex education. I have 3 girls. They were all assigned female at birth, 7, 5, and almost 3. And I will tell you, they will know their parts and pieces. They will know what their menstrual cycle is, and they will definitely know how to take pleasure into their hands.
Yeah, I've had patients that, don't know certain parts, and they're pregnant, having sex, they don't know anything. And I'm like, okay. You're right. You're very much right. So we wanted to ask if you can touch a little bit on starting your own business, having your own clinic. Can you talk about what told you to and you just touched a little bit on it, wanting to kind of move out of hospital medicine, but can you tell us more about how it's like starting your own business and kind of a day in the life of being an entrepreneur and going into your clinic, how it is from when you clock in to clock out or leave your office, so being your own boss.
Clock in and clock out when you own your own practice.
There's no such thing as that.
I knew, I guess it was about a year into, again, being a PA that I needed more. So I also went on to the University of Michigan. They have a certificate program in sexual health. So I am a nationally certified sex counselor and educator through their program and then through this national program. The really cool thing about sexual medicine and really anything, so, oh my goodness, I'm blanking on his name, but his last name is Akel. In the 1970s, this researcher developed what's called a biopsychosocial model to medicine and diseases, right? We can look at the biology side of things, it's medicine, it's disease processes that influence how we affect. Then it's the psychological, right? Do you have support? Are you depressed? Are you anxious? What's your interpersonal relationship? Do you have support at home? Right? We think a lot about moms. I'll take me for example, right? I'm this career woman. I love my job, but yeah, I have a family too, right? So who is at home helping me to support some of these domestic types of responsibilities with getting supper ready and doing laundry and things like that? And then we have like the socio-cultural side of things too that have lots of influences, right? If you don't have access to a healthcare facility because you live out in a rural area or whatever. So he kind of developed this, and we utilize that model a lot when it comes to sexual health concerns. So when I went to the University of Michigan, I loved that. I wanted to have a medical provider. I wanted a pelvic floor physical therapist. I wanted a sex therapist, mental health, social worker. I wanted everybody under one roof. And I realized this too when we talked about this cancer conference, that I was at, and we have the nutritionist there and the pharmacist, the primary care, and the social worker, and the radiation oncologist. We had everybody in one room. And I thought, what if we had everybody in one room for sexual medicine? What if we had this practice that had everybody under one roof, so that we were all working together for the greater good of this patient? So I always had that piece in my brain. I developed a penile rehab program for my patients that had gone through radical prostatectomies or any kind of prostate treatment after prostate cancer. So I had a patient who was in his mid-50s, had pretty aggressive prostate cancer, had a robotic prostatectomy with lymph node dissection, and struggled a lot with incontinence and obviously erections afterwards. So my urologist said, hey, I want you to go see Aleece. She has this penile rehab program and everything else. So I put him into this program, and after about a year of being in the program and doing all of the exercises and treatment modalities, he started having spontaneous erections on his own, and he started so excited and everything. So he just started following me every 6 months for his routine PSAs, for his prostate cancer checkups. And he knew I loved medicine. So, one day we were just, shooting, have conversation and whatever else. Because again, that's how I interact with my patients. We just don't talk about, their disease. I want to know, how are you doing? You drive race cars, how is that? Whatever else. And he looked at me and he said, Aleece, what do you want to do when you grow up? And I said, that's a really good question. I would love to have my own business. I would love to have, again, this biopsychosocial. We have everybody under one roof. I was about about 6 years in from being graduated and being a PA, and I said, I am too young, I'm too early on in my career. And he said, no, you're not. You need to get me a business plan. He was a business guy. He had helped lots of other people in the business world. He said, get me a business plan and let's make this happen. And I was like, he's giving me permission, right? This is the sign that I needed to say yes. And so I got together what I thought was a business plan, because remember, they don't teach you this in PA school. So Google, right? Google, tell me how to write a business plan. And I got together a business plan and, or what I thought was a business plan, gave it to him, and he said, Aleece, this is not a business plan. You have to think about, you know, what your patient population is, what are the things that you're going to be treating, what does your overhead cost look like, right? I missed the whole cash flow thing, right? I'm not, like I said, I'm not a business person. So I actually went to a business class and took some introductory, like Business 101, developed my business plan, hired a business coach so that we could really sit down and look at it, came up with my business name. And this all happened, it took about 3 years. So I had, again, my last baby in 2019. I took my business classes in 2017, early June year 2017, and really started that whole process of, okay, like, this is really what I want to do. We knew we wanted to, like, complete our family and things like that. So yeah, I had last baby in June of 2019. On maternity leave, I knew that I was ready, because I actually had pitched this idea to my hospital system. And I kid you not, when they said, we see no value in this, I was pissed. I was like, excuse me, you're telling me everything that I'm doing right now in my current practice has no value to you. So anyways, that was just very unnerving. I said, okay, fine, I'm just going to do this on my own. Like I said, that's when I took these steps. And on maternity leave in 2019, I found a space over in Asheville. We signed leases January of 2020, like got this space, and we're going to start construction. Right, 2020. Are you all listening to this? 2020, right? So March of 2020 happens, and it's COVID, right? And I put my notice in. I had a 90-day notice to my job. February 26th of 2020, I put my notice in. A week before the world shut down, right? Divine intervention was happening there to tell me you've got to do this. And I think if I had waited to see maybe what COVID was going to do, then I don't know if I would have done it, right? I think I would have been really scared and not knowing. But I signed my lease March. I think it was March 6th is when I signed my lease for the space. Construction started. This was big open shell, so we had to, upfit rooms and do all of this construction. So they started in April of 2020 with all of the construction, and we opened up the practice in June 26th of 2020.
How was it like opening with COVID? Like, I mean, people were kind of scared to leave their house. And, I don't even know how you ended up doing construction because, we were on lockdown for some time. So, I'm glad you got everything up and working, but like opening a business throughout a pandemic, like, that's crazy.
It was super crazy, but there was so many changes that happened, I think, within those first 3 months of COVID, right? We really transitioned a lot over to telehealth. There's so many PAs that were doing virtual medicine way before COVID, right? This is not a new concept, especially in the mental health world, right? Again, we talk about access to care. It is making sure that we can connect with patients. And so, telehealth has always been a thing. It's just we never had it on a large scale within hospital systems. So for us, we saw patients. You could only come back with one person. We had to wear masks. We did a lot of cleaning. We did a lot of adjunct appointments that were telehealth and things like that. And I had already really established myself as this sexual medicine guru, before we opened. And I did a lot of advertising and a lot of letters to my referring providers in the area to let them know, hey, I'm leaving, this is where I'm going. And I will say that first month, the only reason that we really survived is because all of my patients that saw me in my previous practice saw me in my new practice. So I had very few actual true new patients in July of 2020. It took us those 4 weeks to really get the word out. And I would say then from there on out, the majority of my patients have been new. A lot of people, it's word of mouth. I would say 50% of my referrals are word of mouth from friends. Again, in the queer community, spreads like wildfire. There's a safe space for somebody to go to get affirming healthcare.
Yeah.
Like that's where you want to go. And so, you know, we have gotten to the point with me, my medical assistant and a front desk person. That's who we started out with. And
did you have to have a supervising physician or a medical director?
So in the state of North Carolina, because it's different in every state, in the state of North Carolina, a PA can own their practice outright, 100%. But if you go to hire somebody who has a higher degree than you, so MDDO, you need a 1% owner who's a physician to have that 1% ownership of that practice. So I went ahead and set that up as having a 1% owner. And so this urologist that I had worked with such a long time ago, because he left the previous practice about 4 years before I opened my own practice. So he's my 1% owner. He's my supervising physician. You know, North Carolina is really pushing forward for optimal team practice. So I'm hoping that eventually I won't need that supervising physician. But again, we just, you know, check the check boxes and, you know, we meet every 6 months. You know, yeah. And I have him on my cell phone. Like he's an hour down the road if I need him. You know, but again, he taught me everything that I know when it comes to urology and procedures. You know, I did a lot of training on my own when it comes to sexual medicine. And so, but, you know, like I said, again, for me, I had it set up that way. But he doesn't have to be on site. He's been to my office like twice in the past 2 years. So yeah, so, you know, as far as like entrepreneurship too, you know, there's things that you don't think of. You got to put the business hat on, you have to put the PA hat on, and which hat do you wear? You know, there's lots of days where my office manager will come up to me and say, you know, hey, we need some supplies for this. Is this okay? You know, we need credentialing, we need all of these things. So it's been a really big learning process, but it's been so much fun. I wouldn't change anything. It's so nice to be my own boss. You know, I get to make my own hours. You know, we work Monday through Thursday. We have Fridays off. We work hard, but we play hard. I have a great team, which is great. We started off with 3 people, and now we have a staff of 10. So in not even 2 years.
Right?
Yeah, so I have, thank you. I have a pelvic floor PT. I have 2 pelvic floor PTs now. We just hired one. She just started today. We have 2 sex therapists, and I'm actually hiring an integrative medicine PA, and he will start in July. With what I do, and it's so specialized, again, my queer community needs primary care too. And I don't do that, right? I've been doing urology my whole entire PA career. So being able to expand our services and meet the needs of our community and having somebody who is queer friendly, understands queer to health, can treat diabetes, they're going to do med management for depression and anxiety and work really closely with our mental health therapists. Like to have all of that under one roof is just so exciting. We have case discussions for an hour every week where we all get together and we have cases that we talk about, because again, that was so important to me. I wanted team-based care with the patient as our main focus. So I get to do that. We've expanded our location, and so we have a bigger location now. So it's just crazy. I knew that there was a need in the community. I just had no idea how great it was.
Yes, you're gonna have patients from other states coming to see you. Like you're gonna be.
I do.
That's
yes.
amazing. That's amazing. So thank you so much for that. So before we go, we wanted to present a case study, like a common case study that you see on how you were treated as a PA.
Yeah, absolutely. So, right, it's just asking those questions of, you know, digging to find that information. And when it comes to sex and sexuality, right, those conversations can be really tough. So I will say, you know, yeah, in my, you know, day-to-day basis, you know, I come in, I look at my schedule, whatever else. Majority of the patients that I see are going to be, again, female identified, assigned female at birth, cisgender, that are coming in a lot of times for low libido or menopausal symptoms. So, right, so we're having that conversation of, you know, what have you tried? What has worked? What's going on? What makes, you know, the symptoms worse? And so when it comes to a lot of painful intercourse and penetrative activity, a lot of it has to do with, especially with my menopausal women, right? Vaginal dryness is a real issue. We forget that there is estrogen and testosterone receptors in the genitals. And so as women are going through that transition, the thinning clean up vaginal tissues, loss of architecture when it comes to the vulva. There's less elasticity. So I do a lot of education. A lot of times, remember we talked about like patients just to know their own bodies and how amazing hormones are for them. So we talk about that. Let me tell you, if somebody is having a pelvic concern, please do a pelvic exam. So many things are missed because we don't have time, right? You're being pushed to see patients, whatever else. I do a pelvic exam on almost all my patients unless they don't have a pelvic concern, right? So I want to see from my own eyes. I have had so many patients that have said, well, I just saw a gynecologist 2 months ago and they told me everything looked fine. And when I go to look on their pelvic exam, it is not fine. That is not an okay vulva. Absolutely not. Like there is redness and paleness, and there's this loss of this beautiful sheen that the vulva actually has, right? So we talk all about that. I'll get the mirror out. We go through anatomy. We go through all of that. And the biggest thing too that I will say that I implement is what are called consensual pelvic exams. I am always asking permission from my patients. So just because they made an appointment because they're having vaginal discharge or having pelvic pain does not automatically give you permission to do an exam, right? That's a very vulnerable thing for somebody to come up with and to start talking. So asking permission. And I always tell them, you are always in charge. You are the driver in the seat and I am Google Maps. Right? Yeah. You are basically telling me where we're going to go, when we're going to go. You're going to put the brakes, take a rest stop. Like, that's it. That's all. I am just your navigation. And so, and that really, I think, alleviates a lot of things. And even if you just can stop and breathe with a lot of those patients, that's going to make that exam so much easier. And trust me, as a student, you're like, I don't know what I'm doing when it comes to pelvic exams, right? So one of the first things to do is just touch their thigh. That's a great way. You're going to feel me touch your thigh. And you can just work your way down to their vulva, go up over the mons. That's going to give you some peace of mind. You can calm yourself. The patient can calm themselves. I talk to them through that whole thing. I tell them exactly what I'm doing before I do it. Make sure that you look in all of the nooks and crannies in the vulva. There is so much beautiful anatomy that we miss. We think that we've got to go for that speculum, go for that cervix, do our swab and get out, right? There's so much more to it. So that's really, what I would stress. And I see that's probably one of my most common things is somebody having some sort of pelvic concern, pelvic exam is typically what I do. And somebody who's a vulva owner. So that would be, the things to think about. And just looking again at that architecture and just making sure that you're not missing anything.
So much. Thank you for that. This has been an amazing session. You shared so much knowledge. I really appreciate you talking about your journey and everything you know. You are the guru, literally for sexual medicine. Thank you so much. And the one last thing that I always ask our guests is if you have one last piece of advice for the students, one takeaway, what would you like to share with the students?
Dream big. And that, so this is how I envisioned my business, right? And this is how I always think. I always dream big. But then I surround myself with people that pull me back in, reel me back in, and help me work my way to get there, right? There are certain steps that you have to take to get there. But dream big, because guess what? You will get there. There's no timeline. Don't set yourself up for a timeline, right? That's going to be the biggest thing. But don't ever let anybody deter you from your dreams. I had so many people tell me that being a female, being a PA, and being a mom, that there was no way that you could do all of this. Yeah. But you know what? I'd love to prove people wrong. Yeah. So
that hospital that told you that there was no need for it, tell them how big your practice is now.
Yeah, I feel like a little regret.
Yeah. Thank you so much for getting so much love in the chat. And saying thank you so much. This was an informative session. This was so inspiring. I'm honored to have gained knowledge about starting a business, how to be the best provider and for my patients in the future. Thank you a million. Thank you, Aleece. I love your dedication and passion for providing ethical care for LGBT consultation. So many thank yous. Thank you so much. And it's like, I mean, a lot of our audience are millennials, so yes, so thank you so much for that.
Yes, no, absolutely. Well, I'm so happy to be here, and please reach out to me on social media. You can find me at Sex.
Can I put your social media for the students?
Yeah, it's at SexedPA. So yeah, so you can find me on Instagram, Facebook, and Fosnight Center is the one that you can follow us on TikTok. So we do have a TikTok account. Yes. So definitely follow
SexMed?
SexMed, SEXMEDPA.
Got it. So you guys have her Instagram. Oh, I think I accidentally typed on it. But yes, so you guys have it. I'm not Aleece Fosnight. I think I will say Aleece. I accidentally when I logged in under hers. I'm sorry. But thank you again, Aleece. This has been like one of my favorite sessions. I love learning about it, especially since, like I said, I didn't really know a lot about what you talk about because it's not really talked about. It's tasteful and good talk here in general, a lot of these taboo topics. So thank you.
Absolutely, yes. And don't hesitate to reach out. I love helping and mentoring people. So please reach out if you've got questions. Please contact me. I would love to hear from you.
Thank you. Thank you so much. Have a good night. So you can end the session by clicking that red hang up. So thank you so much. Good night, guys. Thank you, Aleece.
Thank you. Bye.
Bye.